A 35-year-old man with history of IV drug use is admitted for sepsis due to leg cellulitis. He is allergic to penicillin with a reaction of hives but no anaphylaxis, and he started on empiric IV vancomycin. Soon after admission, his blood cultures grow gram-positive cocci. A Biofire test of the blood culture is positive for Staph aureus. The MEK-A/C MREJ result is negative. Final speciation and sensitivities are still pending. What's the next step for treatment? Is it to continue the vancomycin until final speciation and sensitivities return? Switching to oxacillin, switching to cefazolin, or switching to daptomycin? The answer here is going to be C, switching to IV cefazolin. Let's first go over how rapid diagnostic testing like Biofire can help us in the diagnosis and management of bacteremia. So traditionally, when a blood culture turns positive, you'll first get that gram stain result that tells us whether something is gram positive or gram negative. But then you have to wait another day for that speciation result. And then you have to wait another day for that final susceptibility result. With molecular rapid diagnostic testing, though, soon after you get that gram stain result, within hours, you can get speciation of your bug. And then because these tests check for common resistance genes, this also gives you the opportunity to tailor your initial therapy to be more targeted. So what is this going to look like with Staph aureus bacteremia? First, Biofire will turn positive for the general staphylococcal probe, as well as your more specific Staph aureus probe. And then we'll check for the relevant resistance gene target, which in this case will be the MEK-A/C MREJ result. And when this is present, this means we're dealing with methicillin-resistant Staph aureus, or MRSA. And when it's absent, we have methicillin-susceptible Staph aureus, or MSSA. When we're managing MSSA bacteremia, switching from that empiric vancomycin to something like an anti-staphylococcal penicillin, such as oxacillin or cefazolin, is really important because these two classes, when compared to vancomycin, have significantly less treatment failure and less mortality. There's many factors to consider when deciding whether to go with ASPs or cefazolin for your patient. Some experts recommend going with ASPs, at least upfront in the course, when there's concern for infections with a high inoculum like endocarditis. This is because of something called the inoculum effect with cefazolin, where some in vitro studies have shown increased resistance when cefazolin is tested against a higher amount of bacteria. There's also some retrospective data to suggest cefazolin does worse than ASPs if the inoculum effect is present. On the other hand, though, cefazolin would be preferred if your patient has a non-anaphylactic penicillin allergy, like our patient. Cefazolin also has a much more tolerable side effect profile, especially with nephro or hepatotoxicity. It also has a much lower sodium content, which is important when you're taking care of patients with comorbid heart failure or end-stage renal disease. And its dosing schedule is also much more convenient. So in summary, rapid diagnostic testing like Biofire is a great tool when it comes to diagnosing and managing Staph aureus bacteremia. The MEK-A/C MREJ resistance gene result in Biofire will help you determine whether you have MRSA or MSSA bacteremia. In treating MSSA bacteremia, both ASPs and cefazolin are superior when compared to vancomycin. When deciding whether to go with an ASP or cefazolin, there are many factors to consider, such as the ones listed here on the summary slide.